My name is Ilhem Berrou. I'm a senior lecturer in prescribing at the University of the West of England, and I'm a clinical pharmacist by trade. And on this project, on this study, I'm leading the PPIE activities and also a work package or a set of activities involving co-designing materials that are patient-facing with regards to the intervention that we're proposing. I'm also joined by Zoe, who is the senior research fellow, and she's overseeing a lot of the activities within the study as well. And Josie, who is the newest member of our team, and she will also be undertaking a lot of the research activities, the realist review that we're doing, some of the data collection, data analysis, and so on. Our study is led by Prof. Nicola Walsh, Professor of Knowledge Mobilization here at UWI, and is supported by a diverse group of researchers with statistics, with research methodology expertise, and the expertise that are needed to deliver such a project. We're very proud of this study because we feel that there is a huge need for it and a huge gap. And we believe that if we manage to gather the evidence for the intervention that I will cover, we will be able to possibly improve people's experience with cervical screening. And if we improve people's experience with cervical screening, we'll possibly ultimately improve their engagement. Then more and more people will come and take the test, book appointments to take the test, and will identify more people at risk and intervene early to improve their outcomes eventually. So this study is about increasing engagement and improving experience of cervical screening, and it's about providing women and people with a cervix a choice of positions. So the acronym for the study is CLEAR. Prize goes for whoever spots how CLEAR is made up from this long description of the study. And it's a realist evaluation and implementation study, which means that we will look at this, we will develop a program or an intervention, we will implement it in practice, and we will monitor what happens and whether the intervention works. The way we're going to monitor it is a realist evaluation, which means that it doesn't just see whether the intervention works or not, whether this program works or not. It also looks at why does it work or why it doesn't work for certain groups. How does it work? How does it deliver the outcomes that we want to achieve? So it's a deeper dive into why something works or it doesn't work. A bit of background. A few things we know about cervical screening. So obviously cervical screening is a public health program that is delivered to women and people with a cervix within a certain age. People are invited to come in for a smear test, and this identifies whether women and people with a cervix have HPV virus. The idea is that if people have HPV virus, then they are at an increased risk of having cervical cancer. So identifying the incidence and identifying whether you have the virus you can go down the care pathway and identify whether you actually have or whether you are at an increased risk of developing cancer. Now we have a situation where less people are engaging with cervical screening. People are receiving the invites to go and have their cervical screening done in a GP practice or usually in GP practice, but sometimes in a sexual health clinic. But people are not engaging with that invite. They're not booking appointments. They're not going to that. A lot of women and people with a cervix are putting this off. More women, and because less women are engaging with this, we're likely to be missing a lot of women who may have cervical cancer, but we're not picking that up because people are not engaging with the screening program. Most often, when people are invited for their test, they're asked to lie on their back and with their knees open, and then the sample is taken. The majority of women would obviously report that this position is not very comfortable, and some people put up with it. Some people actually don't engage with the cervical screening process because of this position and what it triggers. The guidelines for clinicians when they are taking the sample suggest that the clinician should offer the woman or the person with the cervix a choice of positions. They can lie in the traditional position on the back, knees open, or they can lie on their left side, like the recovery position, and have the sample taken that way. We and clinicians and the research believe that offering people a choice of positions improves their experience, because people, when they have a choice, they can choose what's most comfortable for them, what's most appropriate to them, and they're more likely to engage with invites when they are asked to book an appointment. So the left lateral position is an alternative position in the guidelines for clinicians to offer it to people. And people lie on their left side, the knee is then lifted and the sample is taken. And when clinicians are trained, supposedly they are trained on providing both, on taking the sample in both positions and offering patients the choice of whichever position they want to. We believe the left lateral position is less exposing, so it's more appropriate for a lot of people who are disabled, severely obese, individuals who have experienced sexual trauma, for example, and it avoids the full exposure of the genital area. So sometimes it's more appropriate, and a lot of women from minority ethnic backgrounds would prefer that because it's aligned with their cultural values and norms. The problem is the choice of having the test done in this alternative position is not routinely offered, despite the fact that clinical guidelines suggest that it should be offered. Clinicians, when we've done a survey, and clinicians report that they lack awareness of this position. During training, the trainer brushes through this position, and they don't focus quite a lot on it. They focus the majority of training on the traditional position. And the alternative position, or the choice of positions, is not even mentioned in the official invite and the literature that you receive with the invite, the leaflets that women and people with the cervix receive when they are invited to take the test. Elsewhere in the world, particularly in Republic of Ireland and New Zealand, women and people with a cervix are routinely offered a choice of positions. And we think this may be why there is a high uptake of or high engagement with cervical screening in those settings. So what we want to do is make the in-person screening test or experience more accessible, more comfortable, improve. So we want to improve patient information around the choice of positions. And ultimately, we want to implement this, this way of working where people are offered the choice of positions, so that they can be, and people are supported to make an informed choice. And ultimately, people who go and have the test done have a good experience that they are able to recommend to others, and they are able to repeat or come back to the test when they are invited again for future testing. So what we want to do is implement a cervical screening program that provides that choice of test positions. We want to work with patients, with clinicians, and identify the challenges at an individual level, at the clinician level, but also at the system level of how things work, to identify what would help clinicians offer this position and what might hinder them from offering that. And we also want to assess the impact of this program. Does offering people a choice of positions improve uptake and engagement with cervical screening testing? And does it improve patient experience? And does it improve the overall experience with the screening program? How we want to do that? We have 3 phases or 3 work packages or 3 sets of activities. The first activity is we want to start with co-designing activities. We want to work with diverse groups of patients. We want to work with up to 30 people of diverse ethnicities, sexual orientation, socioeconomic or demographics, to produce or co-produce multimedia materials that are patient-facing and so that will be useful to educate people about the options that are available. And we will hope to work with a design company to not produce like hundreds of leaflets, but produce resources and materials that are attractive, nice, meaningful to patients, and representative of the diverse tastes and what people want in literature around health and around cervical screening. All the materials will be reviewed by our patients and public contributors before they go out to production through the company. We also we want to work with our clinicians. We want to hold focus groups with up to 20 clinicians to discuss their views on offering this left lateral position, offering this choice of positions, and see what can we do to, or what we can produce together to support them to offer that choice of positions to their patients. The second phase, or the other set of activities, would be to review how it has already been published in the literature about offering this alternative position. How does it work? In which settings? In which countries? For which groups of people does this position work better or work less well? And we want to produce theories on how offering this position works. How does it improve the patient experience and improve engagement with the screening program? We will discuss this with our patients. We will discuss the process of reviewing the literature, what the research tells us, and the theories that we come up with. We'll discuss them with our patients and public contributors as well to make sure that they make sense and they are meaningful from a patient's perspective. The last phase of the research would be to test our theories through implementing this program or this intervention in a number of GP practices nationwide, and monitoring what happens when we implement that. Does it work? Does it get more women and people with the cervix to come up and book appointments? Are people reporting that they have a better testing experience than when they weren't offered the alternative testing position? What happens in terms of outcomes? And this will be later on in the study. Before I move on to perhaps to direct the conversation a bit, is there anything that you wanted me to clarify or explain a bit more about the study or about the set of activities that we will be or planning to do? So I thought it would be useful to have your insight on how do you feel about the aims of this project? Are they meaningful, useful? How can this research help improve the cervical screening from your perspective, from what you got from the description of the study? Your thoughts on the co-design workshops and what we want to do or what we want to focus on with our clinicians, and what should we focus on when we're choosing the GP practices that we want to implement this intervention in? I'll leave the questions in screen, and yeah, it's open discussion. Thank you.